So I'd like to introduce Dr. Mailer, who's a classmate of mine. And Dr. Steve Mailer received his DVM degree from Michigan State University. He completed his internship in small animal medicine and surgery, as well as residency in small animal surgery at the Veterinary Hospital of the University of Pennsylvania. He spent the following 3 years as a part of the faculty at Michigan State University Teaching Hospital and split his time between soft tissue surgery and interventional radiology. So I know we've had a lot of really good feedback from his talks this morning before I was in the room here. So I'm sure some of you have seen him speak, so I think you're in for a treat as he talks to us about GDV. Thank you.
All right. So I hope lunch was good. Depending on what you ate and where you ate, you may feel like you have a GDV. I know I kind of do. Whew. I don't know if Christian was excited about the fact we were classmates. I don't think he was, but maybe enough time has passed that he kind of forgot what kind of classmate I was. But GDVs, love them, hate them, love men, hate them at the same time. I don't know. Definitely a emergency case that I love, and some of them are very challenging. I've certainly learned a lot about surgery and surgical technique and what to do, what not to do from these cases. We'll kind of go through some of my experiences with GDVs and some things that I've learned the hard way. So a couple of disclosures. And so how do we achieve success, I guess, with GDVs? There's a lot that we could put under that list of making us successful. I think a lot of it does come with experience, but I think with every surgery that we do for any reason at all in any patient is how do we avoid the complications? And the only way to really avoid complications is to really know what the complications are associated with that procedure. And I'm not going to go through this exact case. I usually do in a lecture about gastrointestinal surgical emergencies because it was one of the most challenging GI emergencies I've ever had. But the case presentation by itself is an hour long, and it's much more than just GDV. But Trudy represents a great example of one of the more challenging GDV cases that I have had, and so I'll show some images throughout the lecture about him in particular. But when we look at any plan for any gastrointestinal emergency patient or GDV patient in particular, they all come in through our door, sometimes walking in, wagging their tails. Sometimes they come in comatose on a gurney or being carried in, and everything in between. So there's really no cookbook, if you will, for how to deal with the GDV that walks in the door. But I think we should treat them all the same. We go through the ABCs, assess their airway, assess their breathing, assess their circulatory status, and the end is their neurologic status. We want to check off the boxes on those major body systems before we move on and start figuring out if they're bloated or not bloated and any other issues that may or may not be wrong with them. Even if it's the case that we're suspicious of having a GDV that does walk in the door wagging their tail, we do want to assess those body systems, get large bore IV catheters into their cephalic or jugular veins, and start giving them some volume as they may need it sooner rather than later, even if they walk in looking pretty stable. Get some diagnostic blood work, which whatever that looks like in your hospital, whatever your practice normally does, and again, fluid resuscitation, and continually reassess that patient as you're stabilizing them, have stabilized them, and then are doing some initial diagnostics to determine what it is that's going on with that patient. Obviously, the lecture is GDV, so we know that what we're talking about here is the GDV patient. And part of that diagnostic workup is going to be radiographs. And sometimes we do see GDV patients in pretty young dogs, and sometimes other species. But I still think 3-view chest rads is a very important part. We're already going into radiology to take a radiograph to confirm our suspicion. You're already there. I know it's a little bit extra money. And the young dogs, the intention or the indication for those x-rays is a lot of those dogs have been retching, gagging, maybe vomiting. We just want to make sure, are we going into already a complicated situation for the patient with some aspiration pneumonia or not? Obviously, in these older dogs, it's really good just to make sure there isn't anything else going on, like metastatic disease. Because a lot of these dogs are those dogs or breeds of dogs that are predisposed to some pretty awful abdominal cancers or other types of cancers. And do we want to put the pet and the pet owner through a very expensive operation just to find out that there is some other life-threatening comorbidity or some other horrible comorbidity that if the pet owner had known ahead of time, they may not So there are a lot of controversies that I'm sure you're all familiar with regarding GDV, and this is just a handful of them. Why does this happen? And how does it happen? And what's the breed? What are the breeds we have to worry about? And should we be feeding these giant breed dogs from the floor, or raised, or small kibble, or big kibble, or no kibble? Should they be exercising beforehand or after? You know, everything's been looked at. Actually, one of my favorite papers is evaluating the phases of the moon in GDV, which Penn found that the phases of the moon don't actually have any effect. The Super Bowl also has no effect on the frequency of GDV. We actually thought that it did, and it trended towards significance, but was not significant. There are a couple things we do know are a risk for patients that wind up having a GDV, and they're the only ones that are really consistent every time we look at it. Having a close relative that has had a gastric dilatation volvulus, a sibling or a parent, is at risk, a higher risk from having a GDV. So if you have pet owners who know that a sibling of that dog, or a pet owner who knows that the parent of that dog has had a GDV, that patient is at a higher risk. And that's where I would recommend a prophylactic gastropexy. Other than that, we have our at-risk breeds, our deep-chested dogs. We have our at-risk breeds in some of our smaller breeds of dogs, dachshunds, corgis. But all these other things that we've looked at don't always turn out to be true, depending on who's looking at them and what gets published. So we can all have our opinions, and I think our opinions do count for something. We are the experts. Pet owners do look to us for our opinions, and I don't think that any of our opinions are necessarily right or wrong. I think we're there to provide some information. So more on to prognosis, because I think that's important. And I think talking about prognosis is important because not that there's misinformation out there, but I see it happen in our specialty hospital all the time with our ER docs. A lot of dogs get euthanized with GDV that may be due to misinformation. And maybe it's the right thing because, again, I don't know if the pet owners have money or not. I don't know if the pet owners have been through this before or not, had a bad experience. And I don't know the pet owner's belief system as it relates to quality of life for their pet. But I do know that some early papers that looked at risk factors for poor outcomes in dogs with GDV kind of led us as a profession towards using single numbers or single outcomes of a diagnostic test to determine these animals are going to do bad and these animals are going to do good. And that's a starting point, but it's also really dangerous for us to do that. And so a long time ago, a study came out that said if GDV dogs have a lactate greater than 6 at presentation, they're not going to do very good. And that's actually not what the paper said, but that's kind of how we interpreted it and talked about it. And so then everyone that was able to measure lactate in their practices, including universities and specialty hospitals, would have these dogs come in with GDVs greater than 6 and would tell the owners, I got bad news. The dog's probably going to die. And these dogs were euthanized. And that still happens today. And so I think, again, taking a single number of a diagnostic and making some decisions is a little bit risky, a little bit scary. What we do know about lactate, which is really important, is that lactate is still really important to measure, but it's not so much about what that single number is on presentation, but more importantly, what happens to that number during the resuscitation period. How much does that number change? Regardless of what that number is, let's say it's 12 or 14, how much does it change after we volume resuscitate that pet, that patient? Because if we make a big difference in that number, I'm not so sure that the original number makes that big of a difference. And that's kind of what's been proven out here with lactate. If you are appropriately fluid resuscitating that patient, truly appropriately doing so, and have done so, that lactate doesn't really change. There may be some truth behind the fact that this dog is in trouble, not because its stomach is twisted or the stomach is necrotic, but its body is in trouble. It has really responded poorly to this GDV. And now, again, when the stomach gets that bloated and that twisted, there's a lot more going on than just the stomach having a problem. The vena cava has been compressed for a long time. The portal vein has been compressed for a long time. The entire body has been affected by what's happening. So a lot to consider there as far as it relates to lactate. One of the things that really changed the way that our hospital practices and the way I practice as it relates to GDV, and it's really difficult to get a surgeon to change anything. We're so arrogant and self-centered, and so anything that actually changes how I practice, It's pretty important. I mean, that's really amazing. So this is a pretty, I think, an important paper. It proves some interesting things. Looking at the use of lidocaine in dogs with GDV. Now, I think we all know GDVs and patients with splenic disease and patients with all kinds of different diseases are prone to developing ventricular arrhythmia and sometimes prone to developing very dangerous forms of ventricular tachycardia and ventricular arrhythmias. That sure sounds good. Once we see that, we're going to treat these patients, some of these patients with lidocaine or other medications to help deal with that on the acute basis. But the idea of this was, before we even start to see those problems, should we start treating these GDV patients with lidocaine at admission? When we start a volume resuscitation, we start IV fluids, even prior to anesthesia, should we be giving these animals lidocaine? Interesting idea. So looked at a decent number of dogs with GDV and used a historical group of GDV dogs that were not receiving lidocaine or had not received lidocaine as the control group. And what was found is a significant decreased incidence of cardiac dysrhythmias throughout anesthesia and the postoperative period in the dogs that had received lidocaine on admission and getting it during admission, hospitalization, surgery, etc. The biggest thing that was impressive is the decrease in acute kidney injury. Because GDV dogs, just like any really sick dog systemically, is prone to acute kidney injury as part of their disease process. And because of that, those two things, their hospitalization times were significantly decreased. So again, pet owners are saving money. They're saving money. So this is just one of those papers that went, maybe we should change our protocol here. Now, lidocaine is not benign. It has its side effects. But for us as a hospital, making that decision to change this has definitely made a little bit of a difference. Lidocaine's inexpensive enough and was worth doing in our GDV patients. So I think we all know what the GDV looks like, at least the routine GDV, and we want to make sure that we're taking the right lateral radiograph. A normal dog that's in right lateral recumbency for the right lateral radiograph. The pylorus is on the right side of the body, so if we're taking a right lateral radiograph in the normal dog, the pylorus should be filled with fluid. We shouldn't see it as a gas-filled structure normally. But if that dog has a GDV and the pylorus has moved from the right side to maybe the ventral abdomen or over to the left side, it may be filled with gas and should be filled with gas at that point. So if we see the pylorus filled with gas on a right lateral abdominal radiograph, a good chance that stomach is twisted, good chance there's a volvulus there, and we should be concerned that that's the case. Now, if your technicians or you yourself have taken a left lateral abdominal radiograph, pylorus is probably going to be filled with gas. So just double check that the appropriate radiograph was taken to confirm that it's a GDV. So again, it needs to be a right lateral radiograph to confirm that it's a GDV. So they all look different, and not always do you get a very obvious Popeye sign or compartmentalization sign or whatever it is that you want to call it. And you can have a gastric volvulus without the dilatation. And sometimes those look pretty funny. But again, remember, if it's a right lateral radiograph, and you're seeing gas or air in the pylorus, even if it's not a dilation or dilatation, you may have a GDV. You shouldn't see gas in the pylorus on a right lateral radiograph because it should be down and it should be filled with fluid. So, we talk about all these things that we can look at preoperatively to determine if this dog may have gastric necrosis. And that's the lactate story again. So we kind of all looked at, hey, what value does lactate have to be to determine if this patient has gastric necrosis or not, because gastric necrosis may be an indication of long-term outcome and prognosis. And we're all kind of scared of gastric resection and nobody wants to do it. And so there's all these things. Well, we don't really know. I've seen gastric necrosis in that German Shepherd dog who walks in the door wagging his tail, happy as can be, doesn't have a distended tympanic abdomen, doesn't seem all that unstable, and we get him into surgery thinking this is going to be no problem, and we've got gastric resection to do. And I've seen those really nasty, horribly sick dogs that roll in, comatose, attended. This is going to be awful. Fluid resuscitate, decompress, get into the OR. Got a giant dark purple stomach. Derotate them, warm up the abdomen, flush them out, and don't resect anything. So I think GDVs are one of those big surprise cases. We just don't know. I think the one thing that we can do is we can diagnose the GDV off a right lateral radiograph. But most of us have DR and CR systems now. Most of us are working with digital radiography, so we can do a lot of cool things with our imaging systems. There's one absolute 100% diagnostic thing that you can see on an x-ray in a dog that has gastric necrosis if you pay enough attention to it. If you blow up your radiograph, and it's usually going to be on the ventral aspect of the stomach in a dog that has GDV. That's called gastric pneumatosis. And if we can get, where are those lights at? Christian, are you still in here? Oh, I don't know. Yeah, I can do it. I don't know. Are they over here?
Yeah, they come by the door right now.
Oh, yeah. So if you see gas trapped in the wall of the stomach, oh, I'm just going to start pushing buttons. This is not going to be fun, friend. That's the darkest? All right, will you hook us back up when if you see gas trapped in the wall of the stomach on radiographs, that is diagnostic for gastric necrosis. Should never be there. Gastric pneumatosis. Now, you could have a dog with gastric necrosis that doesn't have gas trapped there, but if you see that, you know what you're getting into. There's going to be some degree of gastric necrosis. Now, I don't know if it's going to be 5% of the stomach, 80% of the stomach, but you can start preparing yourself mentally and prepare the pet owner that this is what we're going to be getting into. Or you can have x-rays like this, like in Trudy's case. I don't even know, I had hemoperineum, something's ruptured. Probably Rudy's stomach. So Trudy had the GDV, pneumoperineum, intussusception, and a splenic hemangiosarcoma. So we won't go through all Trudy's case, but that's what Trudy's radiographs look like. We can get the lights back. Thanks, Christian. So, we can get in the abdomen and see all kinds of crazy stuff, and we'll kind of go through this and how do you know what's dead and what's not dead and what do we do about it. But taking a step back, let's talk about gastric decompression, because this is has been an area of controversy or a lot of questions asked about it. I think before we answer this, these animals absolutely should have gastric decompression before general anesthesia and surgery if they are a GDV. Now, obviously, the gastric volvulus patient without dilatation, without gas distension, no need to decompress them. But the ones that are distended, again, we're compressing the caudal vena cava. We're compressing the portal vein. So there's portal hypertension. There's decreased venous return to the heart, cardiac output's down. There's a ton of pressure on the diaphragm. So we're not getting good lung expansion. So oxygenation could be down. And they're uncomfortable. So what are our two main types of decompression? One is percutaneous, gastric or needle trocherization or decompression, and the other is orogastric. And I'll have people, I'm sure, in this room that say, I am never doing orogastric decompression. I'm going to shove that tube down there and I'm going to rupture that stomach. And then I'll have people in here say, well, I'm never doing percutaneous trocherization because I'm going to hit that spleen and it's going to bleed and now I got to do a splenectomy. I think you're both right, and I think you're also both wrong in the sense that it doesn't really matter which one you do. The risks are pretty similar. The outcomes are identical. The goal is just to get that stomach decompressed more than anything else. Release the pressure off the cava, release the pressure off the portal vein, take the pressure off the diaphragm. That's all that really matters. Now, I will tell you my preferred choice is to do orogastric intubation. I think I can keep that tube in place. I can keep it in place while prepping them, while they're under anesthesia. I can roll in with that tube in place. I don't have to worry about that stomach distending again. That's just my personal choice. Now, you can say, well, I can trocarize that dog 10 more times and do the exact same thing. And that's okay, too. As long as we have them decompressed and keep them decompressed as we're prepping them and rolling them into the OR, they're going to be a much, much better anesthetic candidate, much, much more stable. So really no big deal here. There's one that's not better than the other. So if you're doing one right now and it works for you, do not switch. If you're doing the other, do not. There's no need to switch what you're doing. As long as you're doing one or the other, stick with it and keep these dogs decompressed. So again, I just like orogastric intubation. I like getting that in there. I like having it in there. I like keeping it in there. It keeps them decompressed. I don't have to worry about it when they're under anesthesia. I don't have to worry about it when we're rolling them on their back and shaving their bellies and clipping and prepping and rolling into the OR. That it's going to get any worse. So again, just my opinion. It's certainly not better than doing it the other way. We still have information intruding there. I tried to get all that out of there. So let's talk about when do we operate on these guys? When do we take them to surgery? Really as soon as we possibly can. Once they're stable enough, once they're decompressed. And our goals are pretty simple. We want to correct the gastric malpositioning if it is still malpositioned. I think, if you've done enough GDVs, once you get them decompressed, some of these guys flip back on their own, which is just the best in the world. So those of you that don't mind doing abdominal surgery, but you can't stand GDVs because you get in there and you're like, I don't know how to untwist that. It says clockwise, counterclockwise. I can't figure out how to untwist these. The ones that untwist back on their own, they're great. Quick gastropexy, go home, everybody's happy. So that does happen sometimes, but we need to get them untwisted, keep them decompressed, do a complete abdominal exploratory. If there's a pneumoperitoneum, identify the source of it and deal with that. And then again, if there's any evidence of perforation anywhere, obtain cultures, prevent reoccurrence, which we have to do in any GDV or GV case. And we'll talk about that. So when we look at what happens to the stomach when we're dealing with the traditional or typical gastric dilatation volvulus, again, when you look this up in a lot of textbooks or you're taught it, you read a lot about the stomach twisting clockwise and counterclockwise. And I think that is a very difficult and actually kind of just a mean way to teach students about GDV, because clockwise and counterclockwise in reference to what? Dog on his back, dog on his front, standing on your head. I mean, that's just not fair. So I think we're all very comfortable with the fact that if you have a dog in surgery on its back, left and right, dorsal and ventral never change. The dog's left, the dog's right, dorsal and ventral. So that's how I like to communicate it and talk about it. If you're in surgery and the dog's on its back, we'll approach it from this position. The way that the stomach twists, the pylorus is always on the right, the fundus always on the left. The pylorus moves from the dorsal aspect, and the pyloric antrum, the dorsal aspect of the right side, and moves to ventral midline. So from the right side to ventral midline, and then moves over to the left side, and oftentimes becomes now a dorsally located structure on the left side. Starts on the right, moves ventrally to the left. When it does that, it kind of displaces the body and the fundus, either ventrally or all the way over to the right. And that's typically when we start to get that gas distension. Now, some people say, it's chicken or the egg. Typically, you can get gas distension and then the volvulus. But I think it's pretty hard for the stomach to twist and untwist when it's so distended with gas. Actually, we can finally put the chicken or the egg question to bed. Does anyone know why? Because the egg developed way before birds ever came onto the evolutionary scale. So, question answered. If you guys ever get asked that. Anyway. The egg came before the chicken. So large clip and prep, getting ready for surgery. Try to make an incision from xiphoid to pubis. You're going to need a lot of room in a lot of these patients to get in there and work with the stomach, get it untwisted, get your gastropexy done, especially in these large, deep-chested dogs. You really want to also be able to do a complete abdominal exploratory. A lot of these dogs may have some other things going on. You want to be biopsying the liver, you may have to do a splenectomy. So really check out the whole peritoneal cavity if you can in these patients. So untwisting the stomach, we talked about how it twisted. And so untwisting it is really just the opposite of that. If you're a right-handed surgeon and you're standing on the right side of the dog, and now the pylorus, which was on the right, came to ventral midline and now is on the left. So you're going to reach over from the right side over to the left body wall, and I actually just follow my hand down the left body wall. I stay on the body wall, and I'm reaching kind of cranially in the abdomen, and I feel for the pylorus. So the question is, what does the pylorus feel like? Anytime you do an abdominal exploratory, let's say it's for a cystotomy, let's say it's for a jejunal foreign body, let's say it's for a liver biopsy, take a moment to feel the pylorus. Get a good idea of what that feels like. It'll make your life, when you're doing a GDV, a lot better, because you may not be able to see it. In fact, you probably won't be able to see the pylorus. But if you know what it feels like, and you're reaching down the left side of that body wall, and you grab that pylorus, it's very safe to grab the pylorus and just start moving it, pulling it towards ventral midline. So grabbing it on the left side, you're moving it towards ventral midline, the opening of your incision. Maybe you're gently pushing down on that body and fundus. It's a lot easier to do all of this if the stomach's decompressed. So let's say you were doing trocharization percutaneously before you got into surgery to decompress the stomach. Once you get in there, this is where I'd have your anesthetist, your technician, whoever's working with you, try to pass that tube. You can help guide it because you can feel the esophageal hiatus from the abdomen. Try to guide that tube in, get that stomach decompressed if you can. If it's gas, if that dog ate a 20-pound bag of kibble and now it's just distended with kibble, good luck. You know, you're not going to decompress it unless you're going to do a gastrotomy. Hang the stomach over the edge of the table and do a garbage bag and empty it that way, which sometimes you actually do have to do. But reaching down on the left side, feeling the pylorus, gently pulling it towards ventral midline. Usually when you get to ventral midline, that stomach wants to go back to where it was, not back to its volvulus state, back to where it originally started from. The pylorus wants to be on the right side. And if it has done that, there should be no omentum covering the stomach anymore. The omentum should never be covering the stomach once it's in its normal position. So if you open an abdomen and the omentum is covering the stomach, you know that you're still in that GDV or that volvulus state. So then assessing viability. You know, most of the time when you get into a patient that has GDV and still distended and still twisted, that stomach usually looks pretty unhappy. Whether it's red, bright red, purple, dark purple, don't panic yet. Don't call the owner yet. Don't walk out of the OR yet and say, I've got bad news. Get it untwisted, get it decompressed. Maybe fill the abdomen with a little bit of warm saline, do an abdominal exploratory, come back, take a look at the stomach. Because I'm sure those of you that have done GDVs or a lot of GDVs have seen some pretty horrific looking stomachs become pretty pink or dark pink, or maybe a little bit on the medium red side after you've untwisted them, decompressed them. Well, when you first opened the abdomen and you saw them, you thought, hey, this is not going to go well. And by the time you were done doing your exploratory, you're like, actually, we're okay. We can close this guy up and get out of here. Other times, not so lucky. That was Trudy down here. Big, dead, open, necrotic stomach. You know, dark red, purple, even dark purple. We can deal with that. We don't have to resect that. Yeah, you start getting into black. You know what's worse than black GI? When it's like gray and white. Like, that's the worst. It's firm as can be and it's like gray and white. That's worse than having that dark black GI structure. This is pretty bad. So we assess the viability, and what we do know, at least what we think we know, is that those dogs that we don't have to do gastric resection in have a pretty decent survival rate. If we're really good at our stabilization, our anesthesia skills are good, we get them off the table, we continue to do good post-operative management. Most of those guys do pretty well. Gastric necrosis, it's not because their stomach's necrotic that they don't survive. It's usually by the time the stomach is necrosing, systemically, those dogs are in bad shape. Again, cardiac output's been bad, acute kidney injury is present. There's a lot more going on. It may be bacteremic, it may be septicemic. It's not just because the stomach is necrotic, it's everything else that's happening. So again, that's a pretty awful color when we first get in there. Doesn't mean it's doomed dog, doesn't mean that we're doing gastric resection yet. Horrible color. Again, there's that black color. I don't like that. And it's starting to turn a little bit gray. That's probably going to need some resection. That's unfortunate. If you see the rugal folds when you open the abdomen, you're probably going to need to do something about that. So let's talk about gastric resection. I think that's one of the things that people are most afraid of. You know, I don't like doing GDVs because if I have to do gastric resection, I'm out. So I'm just not going to do them. And that's fair. It's scary, I agree, especially if you don't do them all the time. But if you're going to have to resect anything, so how many of you are just, I'm not doing gastric resections, like just ain't going to do it. All right, you don't want to resect, that's fine. Or you're all really, and maybe you all really like gastric. But what I find is that a lot of people that don't want to do gastric resection are very comfortable doing intestinal resection. I think intestinal resection anastomosis is a lot scarier than doing a gastric resection, a lot scarier. The stomach is pretty simple. It's like a, I don't know, like a water balloon. It's got a tube coming in, which is pretty important. The lower esophageal sphincter is pretty important. And it's got a tube coming out, the pylorus. But everything in between is really not that important. It's just not. Like, you can get rid of a bunch of that. You know, it doesn't have to look good. It could be a triangle when you're done, or like a hexagon when you're done. Or it doesn't really matter the shape. As long as that lower esophageal sphincter is intact and the pylorus is intact, probably not going to change the quality of life of that pet at all. Even if it's a teeny, teeny little ball now when you're done. So maybe some soft food fed frequently, small volumes for a few weeks. I mean, we know people that have stomach stapling or stomach volume reduction surgeries done, and you know, if they don't follow the directions, that stomach stretches out to normal size pretty quick. And we force that onto these dogs. In a few weeks, their stomach volume will come back pretty close to normal, if not normal. So you can resect a tremendous amount of the stomach and not have any major impact on quality of life of these dogs. And again, it doesn't really matter what it looks like afterwards. So I think that's the biggest fear, I think, to get over in these GDVs. Now, what I'll warn everybody about is when you start to do gastric resection, even if it's a small area, and you see the inside of the stomach, you're like, oh my God, what have I done? The mucosa oftentimes is completely black on the inside. And that makes sense. The mucosa takes about 80% of the arterial blood flow of the entire stomach. So it gets hit really hard, really fast. But that doesn't mean you need to resect any of that. It's going to slough, and it's going to auto-digest, and it's going to be okay. I mean, that doesn't feel good, I'm sure. That's why a lot of these dogs are nauseous. It's basically a giant gastric ulcer, at least a superficial one, and we can help them heal that. But you don't need to resect any of that. It's just that full thickness area that turns black or gray or white or is perforated that we need to resect. So if you see that the mucosa is black, don't worry. And again, it doesn't matter how much you're taking out, where you're taking it out, as long as you keep the lower esophageal sphincter intact, as long as you keep the pylorus intact. And you can remove those things, but that's where quality of life may start changing, and that's where another conversation needs to be had. On the bottom, there's just the oral gastric tube that you're going to see. And you can take a blade, you can take scissors, just start getting rid of everything, kind of like dealing with wounds. Necrotic, take it out. Doesn't look good, take it out. And I know I'm sounding very cavalier here, but a stomach is just such a forgiving organ that we can do this in. So we kind of take advantage of that. Everything with gastric tube. And then again, we close it when we're done. It doesn't matter what it looks like. It really doesn't. It's going to look bizarre. It's going to be a funny shape. But just make sure there's a tube coming in and a tube coming out, and we're okay. So you'll see necrosis in all different areas in these GDVs. A lot of times it is on that dorsal surface. It can be up closer to the esophagus, which is a little bit more difficult to see. But again, because the stomach, when you think about it, the stomach just did a 270-degree flip that you just untwisted. Pretty easy to twist it any way you want to see that dorsal surface up by the esophagus if you have to. So again, we're just going to cut out everything that looks necrotic and just close it. And you can still do a two-layer closure here if you want. We're going to talk about in the next lecture closing the GI tract, but still do a two-layer closure. You still have plenty of volume here to do that. The submucosa is the collagen-rich, collagen-dense layer of the GI tract. That's your holding layer, simple continuous through that, and either a simple continuous through the seromuscular layer, the outside layer, or an inverting closure. If you removed a lot of the stomach, probably stay away from an inverting two-layer pattern. Maybe a simple continuous through the submucosa, mucosa, and another simple continuous through the seromuscular layer. So I get asked this a lot too. If you have gastric necrosis, can we just do one big inverting pattern and invert that entire necrotic area into the stomach? And a lot of people do that. And what you're relying on is that the stomach is auto-digesting that big necrotic area over time. And what you're hoping is that the serosa somehow heals itself to the serosa before the stomach eats through itself. Because then you're going to wind up with a giant ulcer, perforation. And although a lot of people have done this and said that everything goes great, there's also a lot of reports to the contrary, that those animals come back with perforations, but those animals come back with severe ulcers and severe gastric hemorrhage and have to go back to surgery for resections. So the idea is a good one. Hey, why not just do a quick inverting pattern and get out of there as quickly as possible? We don't have to do gastric resection that way, but enough reported complications of doing that, where again, kind of like we're talking about with wounds, you know, the overall cost of treatment becomes very expensive when things like this happen. And going back for a second abdominal surgery sometimes is so cost prohibitive that it may be a euthanasia. So let's talk about some of our gastropexy techniques, because now we've got in there, we've untwisted the stomach. We've assessed the stomach. Maybe we did a little gastric resection, maybe we didn't. But now maybe the most important part of the surgery is making sure that the volvulus doesn't reoccur. Because that's really the life-threatening part. And there are a lot of gastropexy techniques out there. Again, I think who gets a pexy in general? Any dog with a GDV, absolutely, or a GV, absolutely needs a gastropexy. But there are some, again, I won't say controversial, but any dog that has a first relative GDV should have a gastropexy done on a prophylactic level. Large, deep-chested dogs, maybe. Any dog with a splenic or colonic torsion that is opened up on your table should absolutely have a gastropexy done. They are very prone to twisting just about everything. So it's something that I would do immediately in those patients if you're dealing with a splenic torsion or colonic torsion. There's some argument out there that any dog that has a splenectomy should have a gastropexy. I disagree with that one, but if it's an at-risk breed that has a splenectomy, you're already in the abdomen anyways. You might as well do a gastropexy. But we do know that dogs that have a gastric volvulus or a GDV have a recurrence rate of that GDV or GV, 70 to 80% recurrence rate, if they are not gastropexied, with a mortality rate with that reoccurrence of greater than 80%. So really, it's a mistake for us not to pexy those patients when we're in their abdomen correcting their gastric volvulus or correcting their gastric dilatation volvulus. So for me, recurrence is really mortality for these guys, and we can do a great job preventing the recurrence. So how many of you guys have seen GDVs and dachshunds, corgis, bassets? Yeah, they're kind of fun, a little different, change it up a little bit. How about in these guys? Anybody do exotics? Yeah, not all that uncommon for guinea pigs and some of the other exotics. And they're kind of fun, cute little GDVs. Little baby GDV, little baby spleens on the wrong side, on the right side, little baby gallbladders. They do the same thing, untwist them, pexy them. They don't always live though. John, do yours live? Yeah, John's don't live either, so I don't know. Do any of you guys? Never mind, we'll find out later. If you want a really good read, a good review, take your time going through it, kind of studying gastropexy techniques, if anyone wants to do that. Some of you probably are, whizzes at gastropexy. This is a great publication, great chapter, if anyone's interested. We'll go through a couple of them. There's a lot of techniques out there. Kind of go through, I think, the most important ones, the tried and true ones that are useful to do in your gastric dilatation volvulus patients. These are the ones I would stay away from. They have been proven to have high recurrence rates. Gastrocholopexy, funded gastropexy, so basically left-sided gastropexy. Percutaneous gastropexy, we are getting better at perfecting. This will be great for your prophylactic cases that are like male dogs, and you don't have access to laparoscopy, for instance. Obviously, your female dogs having ovarian hysterectomies, great opportunity to pexy them. But male dogs, minus having a laparoscopy or laparoscopic technology or equipment in your hospital, what do we do for them? So we're trying to perfect a good percutaneous gastropexy technique that actually prevents reoccurrence. Doing nothing is not a great idea. And incorporating gastropexy is suturing the stomach to your linea as you're closing it, which definitely has a high recurrence rate, but what I don't like about it is I have no idea you just did that. And I have to go into that dog's abdomen for a temo abdomen, and I usually wind up making this nice big gastrotomy when I do that, and I get so upset. I get so upset with you guys for doing that. Not that you guys would ever do that. But I deal with a surgeon down the street who does do that and teaches veterinarians to do that, and it's very frustrating. Plus, it actually has a pretty high recurrence rate, so it doesn't make sense. So how many of you are doing the circumcostal gastropexy still? I shouldn't say still. In general, anybody doing circumcostal? If you are, and you're really good at it, you've been doing it for a long time, fantastic technique. I'm terrible at this technique, so I don't do it. And it has a lot of potential complications. So if you don't do it, I wouldn't start doing it now. Rib fracture, pneumothorax, those are some of the complications that people have when they do these, but those people that were born and raised in this profession doing them and are really good at it, phenomenal technique for gastropexy, 0% to 1% recurrence rate with it. What we're doing on the right side is just dissecting out the last full rib, which is usually the 12th rib, maybe the 11th rib in some of these dogs, on the right side, all the way around, and you're making this. We talked about some flaps in the last lecture, actually 2 lectures ago. You're creating a flap in the pyloric antrum, just the seromuscular layer. We'll show this for another technique in a second. And you're wrapping that flap up and through and around the rib and then suturing it back to itself. Very strong gastropexy, actually stronger than it needs to be, and works very well in people's hands that are good at doing it. But again, rib fracture, pain, pneumothorax, some of the potential complications. So a version of that that's a lot less invasive with less complications that works just as good is the belt loop gastropexy. So some of you may be using this. This is the technique that I use when I get very bored of doing incisional gastropexies because it's just a little bit more fun. And the idea is very similar, and these were compared. And again, belt loop gastropexies have the same recurrence rate as incisional gastropexies. If done well, 0% recurrence rate. I know nothing is 0, nothing's 100%, but in all these studies that are looked at, which aren't long term, they're 2 years, they're 5 years, very, very low recurrence rates. So this is the stomach. There's the pylorus and pyloric antrum on the far side, and the left side of the stomach over here, cardiofundus body of the stomach. What you're doing is creating a flap in the pyloric antrum along the greater curvature, with the base of the flap being on the greater curvature and the top of the flap towards the lesser curvature. Again, it's just a seromuscular flap. The submucosa and mucosa are intact. And then you're going to create a nice little window on the right side of the body wall, caudal to the 13th rib. So very similar to where you would do your incisional gastropexy. And this is just through your muscular layers. You're creating the belt loop, if you will. And you're going to just bluntly dissect underneath those muscles. So again, you're on the right lateral abdominal wall, pretty close to where you would do your incisional gastropexy. And that's what it looks like when you're done bluntly dissecting it. And you're going to wrap that little flap that you made in the pyloric antrum through that belt loop you made and suture it back down to itself. So very similar to the circumcostal, except you're not dissecting on a rib. You don't need that rib to anchor this. This is a very strong, very effective gastropexy. So for those of you that do this, you know how fun it is, you know how great it is, how great it works. For those of you that just do incisional gastropexies and you're just kind of getting bored of doing them, this is fun to try. So again, it works very well and easy to do. So incisional gastropexies, which I think is what most people are doing, again, very effective technique. I have my own way that I prefer doing it. I have run into some problems or seen some problems with some of the older ways that are taught of doing incisional gastropexies. So again, just my personal preference for dealing with the recurrence of the GDV patient and also for prophylactic gastropexies. And again, for the prevention of recurrence of the volvulus, pretty darn close to 100% recurrence. But it's not, like any of the pexy techniques, none of them prevent gastric dilatation, none of them. And this is a really important point. How many times have I forgotten to tell the pet owner that? And in 3 months, I get a phone call, "You lied to me, my dog had bloat again, you did this expensive surgery." It's like, I can't prevent bloat with surgery. I can't prevent gastric dilatation, especially if your dog got into a bag of dog food. That is not my fault. I can't prevent that with surgery. Well, I can, but it's kind of cruel to wire the dog's mouth shut. But I can prevent volvulus by doing an appropriate gastropexy. So I always tell the pet owner the difference between the two. Bloat can mean GDV, bloat can mean GD, gastric dilatation, but I can't prevent the gas formation surgically. None of these can. So I tend to and like to make my gastropexy incisions parallel to the 13th rib, caudal to and parallel to the 13th rib in the right body wall. Not everybody does. Some people make them perpendicular. I like to make it parallel, going through the peritoneum, and at least going through the first rectus muscle, internal rectus muscle. And when you're done making that incision, I like to then make my incision also in my pyloric antrum. And I tend to make them following the curvature of the stomach, between the lesser and greater curvature, going through the seromuscular layer. And some people say, oh, the incision in your stomach and body wall should be 4 centimeters or 6 centimeters. And again, 4 and 6 centimeters is very different in a Great Dane than it is when you're doing the choriotoxin GDV. So I like to make my incision the length of the pyloric antrum, regardless of the size of the patient. Take a look at your pyloric antrum, and that's how big I make my incision. That's how long I make it in the body wall, that's how long I make it in the stomach. So instead of picking a number or a centimeter or an inch, and then I start suturing the most difficult area first, which is the most cranial part of the incision and the most dorsal. So I'm going to run 2 separate sets of suture. That's where the stars are. That's where I'm starting my suture line, cranial and dorsal. And I'm going to run that suture from dorsal to ventral on the cranial aspect, suturing the muscle of the body wall to the exposed seromuscular layer of the stomach. And I tie that. And then I start on the dorsal caudal aspect, where that star is. And I'm going to suture the exposed muscle of the body wall to the exposed muscle on the stomach. That muscular to muscular healing is going to prevent that long-term scar that we need to keep this a permanent pexy.
You always do 13th rib?
Do I always do the 13th rib? If it's a GDV and the stomach is then therefore stretched out, I think it's very easy to do that. You know, the stomach is already stretched and I can get it to the 13th rib or caudal to the 13th rib. If it's a prophylactic pexy in some of these dogs, you're really tugging on that stomach to get it there, and so I'll move it a little bit forward, maybe between the 12th and 13th or right over the 12th. And those giant breed dogs, you got to be careful what that diaphragm is actually attaching to. It can come back pretty caudal. And it's no big deal. It really isn't. If you're making your incisional gastropexy and you hear that awful, and you're like, ah, and you get really mad, it's okay. I mean, put a couple sutures in that, and then you can tap the diaphragm and do thoracocentesis that way. I don't like to tell the anesthetist when I've done that because my ego's too big, but it's always best to tell your anesthetist that happens. But yeah, you can come up a little bit higher. So again, this is just making those incisions parallel to the 13th rib. And again, generally I make my pyloric antrum incisions between the greater and lesser curvature. Now, if you have an assistant with you in surgery for your gastropexy, that's great. Towel clamps on the linea, a lot easier to see. Call this the punch technique, but if you have the assistant just put their fist into the body wall, softly, don't actually punch it, it'll bring that whole body wall up so you can actually see it. You're not like, it actually just becomes a lot easier to suture your incisional gastropexy. If you don't have an assistant, we all know how hard this can be to suture. But if you have an assistant with you, very, very easy using those towel clamps on the linea and having them literally just kind of put their fist into the right side of the body wall and just bring it up towards your ventral midline. Gets it done pretty quick. There's a technique going around taught by a surgeon that does an abrasion gastropexy where they kind of rub a 4x4 on the stomach and a 4x4 on the body wall and put a suture in there. And I've actually now seen 4 cases of gastric torsion instead of gastric volvulus. The stomach is twisting on its pexy site, which is just as scary. That's what these look like at surgery when they come into our hospital. And you can see how small this pexy actually is. We take these down immediately. That's, it's a Great Dane with a half a centimeter pexy. Not going to work. We take that down and we redo with an incisional pexy. So hopefully that technique hasn't made it up to Michigan. And tube gastropexies, I use those mostly. I know we're running out of time here for patients with gastric resection. Still a right-sided pexy. But I like these because the dogs with gastric resection are usually going to need some gastric decompression post-op. I may need to feed them enteral nutrition by bypassing the upper GI tract at times. So these work very well too as a permanent pexy, but it's nice to have gastric decompression at times. And this is more Trudy. But one thing that I can talk to you guys about at the beginning of the next lecture is, we'll talk about the beginning of the next lecture. So just some complications, but most importantly, just something to be aware of, is motility issues. Normal dogs that have gastropexies performed really have normal gastric emptying. They have no motility issues. Dogs with GDV that undergo gastropexies, they have a major gastric emptying delay. And we know that dogs with GDV today have a primary motility disorder. And genetic markers now that are being mapped out with the help of some major donations from a lot of the pet food companies and pharmaceutical companies, we're starting to understand the genetic distribution of GDV better, and it is truly a primary motility disorder. But the prokinetics that we would normally use to deal with motility don't seem to have much of a response in these guys. So I think that kind of goes towards prophylactic incisional gastropexy at-risk breeds, but it's why we see so much gas dilatation in those dogs afterwards as well. And for those of you that aren't using Gas-X in those dogs post-op, it works great. So that's how you keep those pet owners from calling you, "You promised me Upexi and it keeps bloating." I just send them home on Gas-X for the rest of their lives and then they don't bother me. So Trudy wound up being a success after all that he had done, although he died of his hemangiosarcoma in 8 months, but the rest of them did well. So we'll talk more about GI surgery in the next lecture.